All right, so extension. And this is probably a really key time to mention this. A lot of your patients are going to come in and they're going to kind of assume more of a flexion posture, but the extension is probably what's going to fix them. And so it's about trying to promote into that as quickly as possible. There's some scenarios where that's just not always the case, but you need to have a really firm, like, we're going to do these flexion things right now, but at some point we know that extension is really what's going to work. And the process is to help understand, like, if it's a discogenic issue, and I'm dropping this big word, discogenic, disc, gen meaning the beginning. If it was started from a disc, then eventually extension has to happen, because the disc probably herniates or protrudes to the posterior aspect, right? And so we kind of think back, and in our mind's eye, we think about how the nerve roots leave the spinal cord, they go through those intervertebral foramen, and the disc is really close, and it just kind of pushes in. And you're going to see a great video about this. It pushes into that. When it does, that's when the problem persists. And so eventually what we have to do is we have to use our body and the vertebrae to literally kind of compress that disc back in and kind of shove it back into place. That's where extension works. So these are my recommendations to start with. And the very first thing is just standing straight. In all the literature that we review about discs, this is kind of where you want to get them to. And once you get them to here, you just start with just subtle back bends, right? And that's just a pretty easy thing. And just keeping our hands on our hips and just subtle back bends. Now, this is also a great screening tool, because if they do that and they go, oh, wow, that hurts, that tells you either the disc is too hot still, like it's just way out there, you just don't want to do that, you'll stay with flexion, or at least neutral isometrics, or it may tell you that it's not really a disc, it could be like a facet, and no doubt we've all had these pricks in our neck, and especially if it's in the back, and you wake up and you're like, oh, I can't lean my head back, right? And that usually talks about the facet joint kind of getting hung. The meniscus that's between the two facets will kind of lay over and get impinged. And so what happens is, as you promote that extension, what happens is you pinch that meniscus, and we'll talk about that this afternoon or this morning. That can cause pain. And so again, that puts them into a flexion bias. They want to be here, and that's what you teach them. But eventually they need that extension. That's normal, right? We want to be able to do these things. So extension's a big part of what we do. Start with standing straight, back bends, and then question yourself, does it centralize or does it peripheralize? If it peripheralizes, you stop. You do nothing else, right? That's a safety thing. If it's causing pain to go down, or it's causing paresthesia, numbness, Deanna used the word yesterday, radicular. Did you guys catch that word? What does that mean? No. Yeah, it's transitioning down from the source. If you get that, you stop and you back off and you stay at your flexion bias. You got it? But if not, then you can carry on. And the very first thing is the back bridge. Now, I noticed, and Ryan and I were kind of joking with each other, the back bridge technique is probably one that is far underutilized in therapy. We just don't use it as much as we should. It's a simple technique though, right? You're just taking the back and you're making it into a bridge. Now, a true bridge does not have to be achieved early. A true bridge means that we get this area in a complete perpendicular line, or I'm sorry, a straight line from our knees to our elbow, our shoulders. So it would look more like that. That's a true bridge. And that's where your extension really accentuates. They don't have to do that though. As long as they're getting some, then we're going to work on that extension component. Got it? So the back bridge is a big deal. The next one on our list is moving to the cat camel. I do want to show you how the cat camel, again, moving from the flexion cat here to the extension camel here. Now I mentioned the Lindsay, and this is something else I want to talk to you guys about. Put in your mind's eye that posterior longitudinal ligament. It goes down every spinous process, right? Bill talked about it. You've probably seen it in textbooks. Then think about the anterior longitudinal ligament. You really want the cat camel to do such a good job in its total spinal flexion and extension that it affects that ligament, meaning that that ligament says, oh wow, I feel that, right? That's how deep it should go. What we know too is that if in the very rare case you have an anterior disc herniation, right? So looking at bony tone, that means that disc came out the front. Most commonly these are not extremely painful, and they almost mimic more of a muscle strain because they go out to one side, they're on the front, and they're like, man, it's definitely back pain, but it kind of like feels, and it will get kind of tossed around as possibly kidney stones, and all kinds of differential diagnoses will exist around this because it would take an MRI scan to find it, and that's largely not done because of cost and time. By the time it's recognized, it's almost asymptomatic anyways. So we just don't ever really catch those. But if it does, what it will do is it will lean into that anterior longitudinal ligament, right? So you have to kind of think all third dimensional there. But when you do the cat camel there, what are you focusing in on? You're focusing in on the extension. And remember, the extension includes the cervical spine and the lumbar spine and the thoracic spine and the sacrum. Everything is moving to here and then back to here. But if they can't do, or they don't prefer flexion, it's not going to matter anyways. Still do it as much as you can, right? People most of the time are not going to come in and say, I don't want to do any flexion. They're just going to say, I don't want to do any extension. That's really what we're going to see. Next is the bird dog. So in this sequence, the bird dog becomes a diagonal event, meaning right upper extremity, left lower extremity, right? So again, it's from quadruped. And what we will do is we will take and very slowly and calmly have them assume that pointing position. Now, if they're unable to do that, it's probably not because of pain, it's probably because of stability. So what you start with is the upper extremity only. Okay? And once they adopt that with no problems, then you bring in the legs. They're heavier. And for the lumbar spine, very delicate. And then once they adopt to doing, you can engage that posterior oblique sling of muscle. Right? And there it is. I like to have them looking up, really accentuating the extension of the cervical spine as well. But some people just don't tolerate that well. So you got to work what you can. And then we fall into this one right here. All right, so we talked about sideline. We talked about hook line, supine, you knew, plantigrade. Now let's bring this one in. This is prone. With prone, all we're asking is, can they get into this position? Well, let's be real. Some of us in here don't like to lay in this position, right? And I'm prone on elbows right now, by the way. I'm on the next one, POE. That's because I'm trying to talk. I'm asking, can they at least get into this, right? So, let's all come over here and see this thing. right? So this is known as a prone pillow, right? That's a space for your head to go in. And what that does is that just adopts for here, right? Or putting their face there, right? So we have these. Most clinics will have these. And so when you're using, look, they got all cute with their spelling, the prone pillow, right? That's the purpose of these right here. And so you probably looked at this and often thought, well, why is this necessary to put people in prone comfortably and give them a space to breathe, right? The traction table has a prone pillow built into it. Most of them do. And this is really not a traction table as much as it is just a hollow table. And so, right, we can just pull it up. A lot of folks are going to have a hard time getting into prone. That's where your log rolling comes in, right? So they have to know how to log roll into supine and then get over into prone. And you will probably find this out very early. You'll say, hey, can you get on your belly? And they'll go, ooh, I don't know, because it's not something they practice. And so just getting them into that prone position. But Noah, would you mind assuming our prone position here? One of the things that we really like about prone is it is an early extension phase. So we see that. Another thing we like about it is, and we'll talk about this more in class this morning, is the decompression that occurs in all of the spinal segments from lying or bed rest, right? And that's what I'll refer to it as is bed rest. That's something that you'll kind of see more tossed around. But what happens here is these segments, they kind of decompress in a unique way in prone than what they would in supine. If it's true discogenic pain, in fact, prone is the preferred position because gravity then takes effect in grabbing that very liquid nucleus pulposus, right, and helping it to come down. And many times what they'll do is they'll have significant pain decrease just from this right here. There's a unique caveat that occurs though called imbibation, that once they stand, there's this kind of sponge effect that occurs and it actually can cause more pain. And so it's a very delicate balance. And we'll talk about that later. But this is prone, okay? And then we advance from here to prone on elbows. So just come up on your elbows. This is commonly called Sphinx pose right here, or Cobra pose also. So prone on elbows, Cobra, or Sphinx. Any of those may be kind of your common words. Just a great little pose. But again, this is just maintained, right, for basically what they can tolerate. And most of you will feel this. Also, as it works at the spinal segment, it also stretches the hip flexors, right? And so one thing that you need to know is if they already have a contracture here, this is going to be really tough on them. And so if you can look and you identify that posture and you can see maybe that they have already adopted like this right here, right? They have a contracture here in their posture. This is going to be extra tough for them to do. Right? So you need to anticipate that. So what then can you do? Right? So you may have to adopt some other extension interventions in your repertoire. Right? From this, we migrate, or actually graduate, I should say, into a prone press up. Right? And so I'm going to leave you here, and so what we do is just take your hands down to your side, almost like you're going to do a push-up. But you're going to leave your hand, there you go, and it comes down. We really want those elbows to get fully extended, right? But that, again, depends on what we're dealt with on the cards of their hip flexors. And so they come back down, and all the way down to the, there you go. Because it's a prone press-up, meaning there you go, back down. Now, what's really kind of cool here, and I'm going to cheat and kind of go, you just keep going there. What if I were to take and say, oh, you have an L3, and I've literally seen PTs do this. You have an L3 disc issue, right? And I can tell because I see your dermatome connection right in here. I could take a gate belt though and strap them down just around L3, and I could really isolate the movement and and just think about it. I'm just taking those vertebrae and I'm shoving that disc back down. Man, they can do those prone press ups and hop up and be like, man, I feel good. Because they've literally taken that disc off of that nerve root, right? And again, it's slow. This is all a gradual process. Eventually, because of the weakness and the instability that's there, it's going to fall back into that nerve root a little bit. But again, it's a process. We just kind of keep pushing it back in, pushing it back in. Eventually, it will, we know discs do relocate over time. It takes time. It takes some scarring to build up to hold everything in there. And that scarring is not as sensitive over time. My first one, I didn't run for 8 months because running really irritated it because of, weight bearing and bouncing and just kind of that. It just hurt. And so I gave up the running and went to a bike, and even the bike hurt for a long time because I was in this long flexed position. But eventually I got over it, and I found kind of some ways to mitigate that. But that's the prone press up. What's next on our list, Kamiji?
Plank.
Oh, back to plank. Okay. Now listen, we could just have them go into a standard forearm, low, high plank. We also could teach them the reverse, right? So go ahead and flip over into supine for me. And I think some people normally call this a front plank, or a back plank. And so I want you to kind of come up and plank with your arms down. Have you ever done that before? There you go. Right? And so it's kind of like a bridge, but a very high level one, right? So I'm thinking like minimal protective phase, maybe mod, but definitely, you want to do this with caution if you're in the mod. I'm thinking this is like that return to activity phase, into your chronic healing. You're just really out there, really trying to give them something to do. Another thing this does is, why aren't you still doing that? I just kind of thought you were strong. Oh, okay. Is look at the action going on of these posterior muscles back here, right? Up here in the thoracic spine, which we just know these things get weak, right? We just know that. We saw that through the kyphosis and through the necks and all these things. Like, man, look at that. You done? Why are you breathing heavy? What's next? All right. This one is, it's well known as the Palloff press. And it was actually introduced by one of there's a few guys out there who you talk about, like McKenzie and Williams, who really just revolutionized spine care. You're going to hear about them again today. This is McGill, and kind of what he did was he developed a kind of an anti-rotational regimen. What we knew is that a lot of rotation just really irritates the back, especially if it's already kind of weak or got some problems. And so people will historically, when they do a lot of rotation, they'll come up and they'll say, this is pain provoking, right? They'll explain it to you. And so what you want to do is you want to give them anti-rotation. And so by that, he developed, number one, the Palloff press. So you may have seen an activity known as a Russian twist. And how do you feel about doing a Russian twist right there? Hang on. I brought you a little weight because I was kind of concerned about you.
Yeah, I would be too.
Okay. All right, so you see this big spinal rotation that's going on, right? Well, we don't want to give people Russian twists, but we still want to stabilize them. Rotation, and did you notice I left this out yesterday? Didn't talk about rotation when we did that in Score Builders or in seminar. Didn't talk about spinal rotation. We did cervical, didn't really get into that lumbar. But don't you all appreciate the ability to rotate, right? And you want to be able to do it strong. And so what this McGill guy did is he said, okay, we're going to do this thing called a power press. And you take a band and you resist from a rotational or transverse plane, right? And you're going to see that here in a minute. And so if I step out with this, I really increase the resistance, and it pulls me this way. So I'm loaded wanting to go this way, but I'm resisting it. So isometrically, I'm resisting rotation. You see it? And then a component is to squat, right? And you can include or take that out depending on what your patient's able to do. And then there's a press component, right? And so you do this right here. And so rotationally speaking, I'm really resisted and isometrically holding this, right? So instead of doing this over and over where I could cause some pain, what I'm doing is I'm holding it here and I'm working within that, right? And this is a pretty light band, so when you try it, you just want to kind of keep in mind that it is a little light. I have this, which is really high resistance. I don't recommend that you start there, but obviously if you get really good at it. So the Palloff press, right? And then something that you won't find in the literature, the Palloff press you will. What you won't find is this next one, PARD. That's something that's kind of proprietary to your instructor here. I just call them that. And what I'm referencing there is a prone anti-rotational drill. And I have kind of a sequence that I use these for. But one of the key things there is to kind of think about, like, even you can use the band to do this with. Or if you had, you know, that's not going to make sense to you. Or if you brought in like a weight of some sort, but you assume that plank position, right? And so kind of the natural tendency is to take and rotate, right? In this is known as what is it called? A row.
Fly.
Well,
Renegade row.
Renegade row. Thank you. This is a renegade row. But notice here, I'm not rotating, right? I'm just using my arm and then really super stabilizing through all of this. Now, a true anti-rotational drill, I'm going to switch arms here on you, may look more like this. Tendency is to do that. You see? Rotate, right? And I'm not rotating. I'm resisting it. So that's just one version of a prone anti-rotational drill. Now, let's be fair. Palloff press, the PARDs, they're not extension stuff. There's just no better place to put an anti-rotational component but extension, as far as what we're talking about this morning. So, jump on those.